So the SIEPSER sliding knot technique has a kit for practicing this provided by Gould & Ophthalmics. I know you'll find very, very handy. And the way I usually do the procedure is I introduce a needle with a swaged suture on the end, and then I go down through one of the iris pillars, across the eye, up through the other side of the iris pillar, and I usually use a cannula into the eye so that I drive the needle into the hollow of the cannula and then back it out of the eye. That then, as I pull it all through, leaves me a suture inside the eye across the defect. In our model, of course, we have to obtain the same thing, but we just bring the suture-like material across the eye, much as though it would look. Because the difficult part that I find many surgeons have is they get sort of cattywonk following where the sutures are going. Tying a nice square knot is helpful, but it's not at all mandatory. Usually a little counter pressure on the other side. You pull the suture out of the eye. Okay, so what we have is we have two ends. We are not disturbing the defect, and we have the two ends of the suture on the same side of the eye. So if you just pretend the loose end was actually the end of the suture, as though you're going to tie a regular knot, then you take your suture and you go over twice like this to make a sliding knot. And you then tighten that and draw it back into the eye over the defect and tighten it. And then that usually stays pretty much in position. There it is. And it's all right if the iris is tugged a little bit as the knot twirls. Then go in and get the distal side of the knot again. Bring that back out. And if you keep that all straight in your mind, then you take the loose end again, and this time go underneath and through again, just to make sure that we have a secure knot, and pull that into the eye, and then line it up over your defect, tie that tight. You have your repair. And you can do this multiple times along a defect. What I usually do is the same old surgical things we learned back in residency. Divide the defect first in half and then do the other pieces as you see appropriate. I hope you find this helpful. It's really saved me many times in the operating room, and I've had this tremendous success in repairing enormous iris defects using this technique. Thank you.